Hello everyone, welcome to yet another episode of our Medimantra classes today. Today we'll be talking about disorders of menstruation. Basically, we'll be talking about menstruation and its disorders. So, till now we have talked about the embryology of reproductive system, the various congenital malformations. We have talked about puberty, and now in continuation of this we will be talking today about menstruation, what actually are the physiology and the pathogenesis of disorders of menstruation. So, first of all, talking about amenorrhea. What do you mean by amenorrhea? So, amenorrhea का केस आता है एग्जाम में. There you can have two types of amenorrhea. You can have primary amenorrhea, you can have secondary amenorrhea. Primary amenorrhea is absence of menstruation, that is absence of menarche. Okay, absence of menarche by the age of 13 years and 15 years. So it is very important. Okay, menarche by 13 years in the absence of development of secondary sexual characters. If there is no secondary sexual characters, then by 13 years, if patient is not having menarche, then it is called primary amenorrhea. If the secondary sexual characters are present, then by 15 years, you can wait up to 15 years. After 15 years also patient is not having any menarche, then it is called primary amenorrhea. Similarly, secondary amenorrhea is patient is not having menses for the last 6 months or for 3 consecutive cycles. 3 consecutive cycles. Then you say patient is having secondary amenorrhea. So, primary and secondary amenorrhea. Now, what are the causes of amenorrhea? Number one, it can be because of physiological causes. Let us see what are the physiological causes of amenorrhea. So, physiological causes of amenorrhea can be number one, it can be before puberty. You can have before puberty. So, before puberty, none of the patients will have menses. So, it is primary amenorrhea. Then after a patient attains menopause, then patient will not have any menses, so this is physiological. Other than that, pregnancy is a duration when patient will not have any menses, and during lactation. These are the 4 times when patient has physiological amenorrhea. Other than that, everything can be pathological causes of amenorrhea. Now, amenorrhea can be of two types. Pathologies can be divided into, one can be cryptomenorrhea. As I was telling to some of the patients in the clinics, what do you mean by cryptomenorrhea? Crypto means hidden. जब समथिंग हिडन होता है, वो छुपा हुआ होता है, उसको क्रिप्टोमेनोरिया बोलते हैं. It means patient is having menses, but the menstrual blood is hidden. Why this is so? This is because if you consider this as the uterus, and these are the fallopian tubes on both the sides, these are the ovaries, then you have the cervix and the vagina. If there is a transverse vaginal septum or an imperforate hymen, consider there is an outlet obstruction in the form of imperforate hymen, or you can consider this patient can have transverse vaginal septum. We had spoken all these things in our last classes. Transverse vaginal septum. In all these cases, patient will have the blood accumulating. Menses तो आएंगे अंदर से, but then there will be shed off of the endometrium, but the blood keeps collecting above this obstruction. So first of all, blood will collect in the vaginal cavity, which is called hematocolpos. What do you mean by colpo? Colpo means vagina, so hematocolpos. After that, blood will keep accumulating in the endometrial cavity, which is called hematometra. Metra means endometrium. And then blood will collect in the salpinx, that is the fallopian tubes. So hematosalpinx. Okay. Similarly, and then there will be hemoperitoneum, blood will collect back. So these are the causes of cryptomenorrhea, that is hidden menses. Menses तो हो रहे हैं, but because of outlet obstruction it is not seen to come out. So this is one of the causes of pathological amenorrhea. Other than that, cryptomenorrhea के अलावा there can be true amenorrhea. True amenorrhea, whereby there is something to do with the compartments so that there is no menses. So let us consider what are the four compartments. सबसे ऊपर तो there is hypothalamus. You all know there is hypothalamus which secretes GnRH, that is gonadotrophin releasing hormone, which stimulates the anterior pituitary gland, and then anterior pituitary secretes FSH and LH, follicle stimulating hormone and luteinizing hormone, which thereby comes and stimulates the ovary to secrete estrogen and progesterone, basically estradiol and progesterone hormone, which thereby estrogen has an effect on the endometrial lining of the uterus, and so endometrial lining forms and then sheds off. So it is the uterus whereby menses occur. So the first compartment 1 is your uterus. So we go for below upwards. तो अगर कभी हम बोलते हैं कि कंपार्टमेंट 1 में there is some problem, so remember it is the uterus where there is problem. Then coming to compartment 2, ovary is always compartment 2. तो अगर प्रॉब्लम हो रहा है in compartment 2, it means there is some problem in secretion of estrogen and progesterone in compartment 2. Coming to your anterior pituitary is called compartment 3. Because we go upwards, and compartment 4 is your hypothalamus. So lower down the problem, the upper hormonal levels will increase. Negative feedback के वजह से अगर ovary में there is compartment defect in compartment 2, then estrogen progesterone will be low, but FSH and LH will be high. If there is defect in compartment 3, the FSH, LH, estrogen progesterone will be low, but GnRH will be high. And when there is defect in compartment 4, then all the hormones in the cascade will be low. If there is defect in compartment 1, as in outlet obstruction, all the hormones will be normal, but still patient will have amenorrhea. Okay, so compartments is very important to know. Next comes your primary amenorrhea. What are the causes? Let us see what are the causes. Basically in compartment 1 it can be MRKH syndrome, where there is problem in the Mullerian duct development. So Mullerian duct development mein there can be problem. Then your testicular feminization syndrome or androgen insensitivity syndrome, where the uterus is not formed properly. So these are the outflow tract obstruction, or there can be imperforate hymen or transverse vaginal septum. Coming to compartment 2, what are the problems in compartment 2? There can be gonadal dysgenesis, Turner's syndrome, Swyer syndrome. So anything where when the ovary is not having secretion properly. And then higher, the compartment 3 and compartment 4 disorders can be your Kalman syndrome, prolactinomas, Arnold-Chiari syndrome, or any neoplasia or hypopituitary states. These all can be there. So the most common cause, okay. So the next question comes, what is the most common cause of primary amenorrhea? Is of course your Turner's syndrome. Okay, Turner's syndrome. Or sometimes if Turner's syndrome is not written, you can have ovarian dysgenesis syndrome also as one of your options. followed by the second most common cause of your primary amenorrhea is androgen insensitivity syndrome. Sorry, the second will be your MRKH syndrome, MRKH, and followed by androgen insensitivity syndrome. So Turner's syndrome, that is 45XO, is the most common, or ovarian dysgenesis, followed by MRKH syndrome and followed by androgen insensitivity syndrome, okay, which is also called testicular feminization syndrome. This is also called Mullerian anomalies, okay, Mullerian anomalies. So basically, how do we go about our diagnosis? How do we go about our diagnosis? So you can just, if a patient comes with primary amenorrhea, okay, get an ultrasound done. You can get an ultrasound done. In ultrasound, try to look if the patient's uterus is present or not. If the uterus is present or not. If the uterus is present, okay, then there can be defect in, what all defects can be there, okay. Number one, try to look for secondary sexual characters are present or not, okay. If the uterus is present and the secondary sexual characters are also present, secondary sexual characters present means breast and axillary hair is present. This means your estrogen is working properly. Estrogen and your androgens are working properly. So estrogen androgen is working properly means ovary is working properly. If ovary is working properly, it means आपका कंपार्टमेंट 2 तक तो नॉर्मल है. अगर कंपार्टमेंट 2 तक नॉर्मल है, देन ऊपर वाला कंपार्टमेंट 3 एंड 4 इज ऑल्सो नॉर्मल. But then, why patient is having this primary amenorrhea? It will be because of outlet obstruction. Outlet obstruction. Okay. So if everything is normal, means secondary sexual characters normal है, इसका मतलब compartment 2, 3, 4 are normal, and uterus is also present, means compartment 1 is also present. So there will be outlet obstruction like transverse vaginal septum, or it can be imperforate hymen. So ये सारे causes यहाँ पे आ जाएंगे, ठीक है. At the same time, if uterus is absent and again the secondary sexual characters are present, okay, secondary sexual characters are present, then it will be, uterus is absent means it can be MRKH or Mullerian agenesis. In Mullerian agenesis, what will happen? In Mullerian agenesis, what will happen? The uterus is absent, but rest of the things are present because ovary is present. So rest of the things are present. This is the thing. Then how to differentiate MRKH from MRKH versus your testicular feminization syndrome? All these things I have already told in previous classes. Karyotyping will be XX in this, karyotyping will be XY in this. You can also have a different type of classification whereby you can look towards the height of the patient. Height of the patient can also be seen. Height of the patient can also be seen. If the height of the patient is short, then most probably we are dealing with 45XO Turner's syndrome. And if the height of the patient is normal, then it could be, what can be there, with try to look for secondary sexual characters are present or not. If the secondary sexual characters are absent and the height is normal, this means there is some problem in compartment 2, 3 and 4. So it can be because of higher disorders like Kalman syndrome. It can be because of Kalman syndrome, or it can be because of Swier's syndrome. So we have actually discussed all these things. I'm not going into much detail of all these things. So basically Kalman syndrome is where I have told there is defect in the hypothalamus. Hypothalamus mein there is defect, and because of hypothalamic defect, hypothalamus migrates from the nasal bone, the nasal area. So there is midline defect also, midline defect at the level of nose also. So there will be anosmia associated with this. So primary amenorrhea with anosmia with hypo, that is hypogonadotrophic hypogonadism, is an example of Kalman's syndrome. Okay, now next, coming to what we actually do in a patient of primary amenorrhea. Okay, so primary amenorrhea may, you have to, depending upon your cause, if it is MRKH or whatever it is, depending upon the cause, you have reproductive outcomes. Okay, so if we consider the treatment of patients with primary amenorrhea, if you consider the treatment, reproductive life, let us consider if it is MRKH, that is Mullerian agenesis. Then what you do is, basically these patients will have normal ovulation. They will have normal ovulation. So you have to go for IVF of these patients. You have to go for in vitro fertilization, and like their ovaries are normal. So you can take egg from their ovary, take testis sperm from the husband and fertilize and form the zygote, and then you can, now their uterus is absent. Okay, so their uterus is absent, so IVF can be done followed by surrogacy means you can use another patient's ovary, can be used for pregnancy. So a surrogate mother can be used, or you can go for uterine transplant. So uterine transplantation is possible in patients of MRKH syndrome. But IVF can be done from own biological egg, because they have their functional ovaries. Coming to androgen insensitivity syndrome, this has the poorest prognosis, poorest reproductive outcome, poorest reproductive outcome. Here what we do is, you have to go for adoption. Why you should go for adoption? Because they do not have, they have absent uterus, absent ovaries. Okay, so everything is absent and they are XY, they are genotypically they are males, so they cannot bear a child. So you have to go for adoption, but they are they want to be females because they are reared up like females. Coming to Turner's syndrome 45XO, in Turner's syndrome, it is possible to do IVF, but you have to take donor ovum. Donor ovum IVF has to be done because patient is 45XO. So streak gonads, ovaries are streak, so they will not be able to produce eggs. So donor ovum IVF is possible, but with surrogacy, possibly with surrogacy. This is because these patients have contraindication for pregnancy. Have contraindication of pregnancy. This is because they have heart lesion. What heart lesion is there? They have generally associated with bicuspid aortic valve. So in that case, they are WHO category 4. WHO category 4 when their aortic valve diameter is more than 50 mm. So most of them are category 4 and they are contraindications of pregnancy because they end up in having aortic dissection in pregnancy, aortic dissection. So basically you can go for donor ovum IVF with surrogacy, can be an option in these patients. Coming to Kalman syndrome, patients who are having Kalman syndrome, they can go for stimulation with GnRH pulse therapy. GnRH pulse therapy, it will help in resuming proper menstrual cycles and patients can conceive. So conceiving is possible. Coming to Swyer syndrome. In Swyer syndrome, actually they are also males and they have the basically there is problem in the gonads. So they are dysgenetic male gonads. They have uterus. So IVF with donor oocytes, donor ovum IVF can be an option in them, but you have to be this has to be followed by implantation of zygote in their own uterus. So since they have their own uterus, they have both male and female organs. So the male organs, the testis will be removed, and the female organ uterus is there. So they do not need surrogacy. Donor ovum IVF can be done, but do not need surrogacy, because they have their own ovary, own uterus is present where implantation can be done. So this is all about primary amenorrhea. Coming to secondary amenorrhea. Secondary amenorrhea. What I have told, what is secondary amenorrhea? Cessation of menses for at least 6 months or 3 consecutive cycles, then patient is said to have secondary amenorrhea. Then secondary amenorrhea can also be defect in compartment 1, 2, 3 and 4, as we already know. Compartment 1 defects can be because of, there can be the most important and common cause is Asherman syndrome. What do you mean by Asherman's syndrome? Asherman syndrome is if there is vigorous curettage of the uterus. This is the uterus, and there is vigorous curettage, DNC. DNC mein there is vigorous curettage. Then what happens? Raw area is created in the endometrium, and these raw areas tend to then stick to each other, and there will be adhesion formation. There will be net like structures formed, and this will lead to crisscross pattern of fibrosis formation. This is called Asherman syndrome. So it is one of the outlet obstruction. Moreover, Asherman syndrome can also be caused by genital tuberculosis. Genital tuberculosis, which is very common in our India, can be another cause of Asherman syndrome. The second compartment causes defect in the ovaries, which we all know. उसमें most important feature is PCOS. PCOS patients or patients of premature ovarian failure. Premature ovarian failure. PCOS will be talking in next class, but premature ovarian failure may always remember. How do we diagnose? If a patient is having FSH value of more than 40 international units per liter at less than 40 years, okay, लेस देन 40 ईयर्स में FSH वैल्यू बहुत हाई हो गया, मोर देन 40, then it is called premature ovarian failure. FSH more than 40 क्यों होगा? Because if ovaries अगर फेल कर जाए तो ऊपर वाले FSH from the anterior pituitary, this will keep rising because of negative feedback. Okay, so FSH value will rise to more than 40 at less than 40 years is diagnostic of POF, premature ovarian failure. Nowadays it is also called POI, premature ovarian insufficiency. Both the terms are the same. Then coming to pituitary, anterior pituitary defects, it can be because of prolactin secreting tumors, prolactinoma, okay, or it can be because of other disorders like Sheehan syndrome. Okay, Sheehan syndrome is pituitary apoplexy. And it can be then coming to your compartment 4. Compartment 4 disorders can be because of psychological disorders, like it can be because of bulimia nervosa, anorexia nervosa, anorexia nervosa. So these all kinds of defects can be there in the secondary amenorrhea, various compartments. Now, how do we go about and test for secondary amenorrhea? When a patient comes with secondary amenorrhea, first of all thing which has to be done is a urinary pregnancy test has to be done. If urinary pregnancy test is positive, then patient is pregnant, of course, then go for that. After that, if it is negative, urinary pregnancy test is negative, then we get thyroid testing done, TSH, and serum prolactin levels done. These are the two things we get it done. Because thyroid abnormalities, hypothyroidism or hyperthyroidism can lead to secondary amenorrhea, very common in our country. And secondly, if the prolactin level is raised, hyperprolactinemia, it will help in decreasing the GnRH secretion and thereby leading to secondary amenorrhea. So these things have to be ruled out. Once thyroid is normal and prolactin is also normal, then we go for progesterone challenge test. Progesterone challenge test. What do you mean by progesterone challenge test? How do we give it? What we do is we give medroxyprogesterone acetate. Medroxyprogesterone acetate 10 milligram twice daily BD for 5 days is given. So, what actually is our theory? Why are we giving? What is our fundamental? See, basically, the menstrual cycle, if you see, then this is the uterus. Okay. In the first half of the cycle, estrogen rises. Estrogen rises. Okay. Estrogen will help in the फॉलिकल रिक्रूटमेंट. फॉलिकल्स बन जाएंगे. फॉलिकल्स बनेंगे तो ईस्ट्रोजन बनेगा एफएसएच के वजह से. Then in the second half of the cycle, what happens? Progesterone increases because corpus luteum is formed, so progesterone increases, and estrogen is a bit low, progesterone is maintained. And in the last part of the cycle, estrogen, progesterone both fall, and when both fall, then the endometrium sheds off and you have menses. So, if somebody is having an ovulation, this means patient is not ovulating. Like in PCOS. PCOS patients may there is follicle recruitment, but patient does not have corpus luteum formation because there is no ovulation. So if there is no ovulation, then this progesterone level नहीं high होता है. Always estrogen level is high. Okay, estrogen level high रहता है. इसके वजह से there is no shedding of the endometrium. So what we can do in such patients, we can give progesterone for 5 days. If you give external progesterone for 5 days and then you stop the progesterone after 5 days, when you stop the progesterone, then this progesterone, since body will think that corpus luteum has formed, so estrogen level will fall by that time, and when you stop the progesterone, then your progesterone level will also fall. So when both estrogen and progesterone have fallen, then patient will start menstruating. So with the progesterone challenge test, okay, give progesterone for 5 days, medroxyprogesterone acetate for 5 days, and then stop it. If waiting, then ask the patient to wait for the next 7 days. If patient has started to bleed, agar bleeding present hai, then there is progesterone challenge test is said to be positive. Withdrawal bleeding, this is called withdrawal bleeding. Okay, withdrawal bleeding. If withdrawal bleeding is present, then it means patient is having PCOS. Okay, patient is having PCOS, or you can say that there was anovulation. The cause of secondary amenorrhea was anovulation. But if the patient is not having any withdrawal bleeding with progesterone, most of the patients will have withdrawal bleeding. But if she is not having any withdrawal bleeding, then we have to proceed to E plus P challenge test. E plus P challenge test. Till now it was only progesterone challenge test. Now we have estrogen plus progesterone challenge test. So what do you mean by this? So when we give E plus P challenge test, you have to mimic the normal cycle. So what will happen is we will take the entire cycle. We will start estrogen to the patients. So what type of estrogen can be given? Either you can give 2 milligram estradiol valerate. Estradiol valerate can be given, available in the market. It is E2 preparation. You can give it for 21 days. You can give it for 21 days. Okay. Or you can give 1.25 milligram conjugated equine estrogen. Conjugated equine estrogen can also be given. This can also be given for 21 days. So for 21 days in the cycle, out of 28 days, 21 days you are giving estrogen. Okay. And what you do is you add medroxyprogesterone acetate 10 milligram OD from day 15 to day 25. Okay, so from day 15 to 25 you add progesterone. This part of the cycle you add progesterone also. Okay, so what will happen is you are mimicking the normal cycle. That is, in the first half of the cycle estrogen you are giving, in the second half of the cycle you are giving progesterone, and then when you stop the medroxyprogesterone acetate, wait for a few days and see if patient is bleeding or not. So if patient has the bleeding, the withdrawal bleeding, this is called the withdrawal bleeding. If patient has the withdrawal bleeding, it means बॉडी में क्या था, बॉडी में ईस्ट्रोजन का डिफेक्ट था समवेयर, और देर कैन बी ईस्ट्रोजन प्रोजेस्टेरोन दोनों का डिफेक्ट मे बी देर. But if the patient is having no bleeding even after that, then you can say कि defect is in compartment 1. Compartment 1, that is, it will be Asherman syndrome. Asherman's syndrome. Okay. क्योंकि सारे चीज़ नॉर्मल है, ईस्ट्रोजन भी दे दिया, प्रोजेस्टेरोन भी दे दिया, उसके बावजूद भी ब्लीडिंग नहीं हो रहा है, तो इट इज़ समवेयर इन द आउटलेट ऑब्स्ट्रक्शन. बट अगर विड्रॉल ब्लीडिंग इसमें हो जाता है, देयर कैन बी डिफेक्ट इन आइदर कंपार्टमेंट 2 और 3 और 4, कहीं पे भी इस ओवरी, हाइपोथैलेमस, एंटीरियर पिट्यूटरी, कहीं पे भी प्रॉब्लम हो सकता है जिसके वजह से ईस्ट्रोजन या प्रोजेस्टेरोन सही से बन नहीं रहा है. ओके, सो देन यू हैव टू check कि what is the level of your LH, FSH and GnRH. अगर LH, FSH, GnRH everything is low, all the three are low, all are low, then the defect is high up in compartment 4. In compartment 4, so it means it can be because of Kalman syndrome. It can be because of Kalman syndrome. If the defect is such that the GnRH is high, सारा चीज़ लो था कैलमिन में, but GnRH is high, but LHFSH is low, LHFSH is low, इसका मतलब डिफेक्ट है कंपार्टमेंट 3, दैट इज एंटीरियर पिट्यूटरी में प्रॉब्लम है. दैट इज वाई despite of high GnRH, LH and FSH were low, and if all are high, all three are high, but estrogen is low, then defect is in compartment 2, that is ovarian failure, premature ovarian failure. Okay. Now one more question which is asked is, what drug do you generally give when there is prolactinemia? Prolactinemia, प्रोलैक्टिन लेवल्स जब हाई रहता है, प्रोलैक्टिनेमिया कब बोलते हैं? व्हेन द सीरम प्रोलैक्टिन लेवल इज मोर देन 25 इंटरनेशनल यूनिट्स, देन इट इज कॉल्ड प्रोलैक्टिनेमिया. इन दैट केस द ड्रग ऑफ चॉइस इज योर कैबरगोलिन. कैबरगोलिन इज द ड्रग ऑफ चॉइस. कैबरगोलिन का डोज क्या है? 0.25 मिलीग्राम ट्वाइस वीकली फॉर 3 months. Okay. So like Monday, Thursday, Tuesday, Friday, Wednesday, Saturday ऐसे we generally give, and we give for 3 months. But the drug of choice for hyperprolactinemia with infertility, if patient is having infertility, so your answer will be bromocriptine. Bromocriptine, because bromocriptine is utilized for ovulation induction also. मीन्स ओवरी में ओवुलेशन कराने के लिए भी इम्पॉर्टेंट होता है ब्रोमोक्रिप्टिन. कमिंग टू वन मोर थिंग विच वी वर टॉकिंग अबाउट वॉज शीहैन सिंड्रोम. वॉट इज शीहैन सिंड्रोम? शीहैन सिंड्रोम इज बेसिकली इट इज pituitary apoplexy. Pituitary apoplexy. Now what do you mean by pituitary apoplexy? Pituitary apoplexy means, suppose a patient is having very much of PPH, postpartum hemorrhage during delivery. So what happens? There is a lot of blood loss. Blood loss हो जाता है during delivery. This can lead to hypotension, sudden hypotension of patients. And sudden hypotension in the brain can lead to less blood flow to the pituitary gland also. So less blood flow to the pituitary gland. So if there is less blood flow, that is apoplexy of the pituitary gland, then the pituitary gland there is degeneration, and this degeneration is also termed as Sheehan's syndrome. In Sheehan's syndrome, all the hormones secreted from the anterior pituitary, like your growth hormone, your prolactin, your FSH, LH, everything gets decreased. And so, one of the symptoms is also secondary amenorrhea. Apart from secondary amenorrhea, these patients will also complain of decreased lactation, so they will not able to lactate their baby, and they will have their menses will not resume after 3 to 6 months, after 6 weeks of the baby growth. Okay, so they will not have this. And apart from that, they will also have other effects, like patient's growth hormone will be reduced, patient will have muscle wasting, thyroid hormone will also reduce, TSH will also reduce, so patient will have hypothyroidism and all symptoms like that. So this is how we go about how we diagnose primary and secondary amenorrhea. It is a short chapter, of course, but many of the patients come to you with this disorder, and basically your management of progesterone challenge test and how do you give estrogen plus progesterone challenge test is very important. So I hope you will be able to manage such type of patients. Try to do the MCQs from this part today, and in next class we will move further ahead and we will talk about the other disorders. So stay tuned to my channel. Thank you for watching today's class.